I think you can see the presentation good. Okay.
Yes, Professor.
Okay. So let's start with cases of cesarean section. From last meeting or last webinar, we discussed some issues about the guidelines in thromboprophylaxis in pregnancy. The first case is 20 years old female attends to the emergency room for normal delivery. From history, she is gravida 1/0. She has gross varicose veins. She didn't need antenatal venous thromboembolism prophylaxis after making the assessment for her. By examination, weight was 85 kilograms. During delivery, obstetrician decided to perform cesarean section due to fetal distress during labor. What about postnatal VTE thromboprophylaxis? From the guidelines, Royal College of Obstetrician and Gynecologists, the major high risk, as we said, at least 6 weeks postnatal prophylactic, any previous VTE, anyone require antenatal low molecular weight heparin, high risk thrombophilia, low risk thrombophilia together with family history. It's not high risk, actually. In intermediate risk, and the first one is cesarean section in labor. This is very important, and she is at the level of intermediate risk. So the postnatal VTE for this female is 10 days postnatal prophylaxis due to emergency cesarean section, and no rule for gross varicose vein alone. The rule here is for emergency cesarean section. I think we stressed this point last webinar, and again we stress because emergency cesarean section alone needs 10 days postnatal thromboprophylaxis. What is the dose of low molecular weight heparin in this case? 20 or 40 or 60? And from the guideline, and according to her weight, we will give her 40 milligram per day. And this is the recommended dose. For the second case, this female is 20 years old, attended to the hospital for elective cesarean section. From history, gravida 1/0, gross varicose veins, didn't need antenatal VTE prophylaxis after making the assessment. Her weight is 95 kilograms. For the postnatal VTE prophylaxis, if we look for this, we can see that we don't have high risk, we don't have intermediate risk, but we have elective cesarean section, which is alone, takes score 1, but we have here gross varicose vein. So we have two risk factors. For these two risk factors together, we need to give 10 days postnatal prophylaxis. Okay, so emergency cesarean section needs alone 10 days postnatal thromboprophylaxis, while elective cesarean section don't need alone thromboprophylaxis, but if we have added risk, we have to give thromboprophylaxis. And the dose here for this female, according to her weight, it will be 60 milligram daily for the 10 days. The third case, and I refer this from the presentation of Professor Salah Rashid, we have a case of 30 years old female attends to antenatal clinic. History, 10 weeks gestation. She's gravida 2/1. This current pregnancy was achieved through in vitro fertilization. She had ovarian hyperstimulation syndrome, and she is a smoker. By examination, she is 78 kilograms. Blood pressure is 120/80. Hemoglobin is 9.8 grams per deciliter. Should she take antenatal VTE prophylaxis? If we look for this, she's a smoker, takes one. She has ART, takes one also. But for ovarian hyperstimulation syndrome, which is in the first trimester, it will take 4 from the transient risk factor. So if we collect this risk, we'll find that we have score of 6. So this female will need thromboprophylaxis, and we have to consider antenatal prophylaxis for her. Score is 6 because she's a smoker, takes 1, IVF takes 1, and ovarian hyperstimulation syndrome takes 4. So she needs antenatal VTE prophylaxis. When we start this VTE prophylaxis, from the first trimester or from 28 weeks, according to the Royal College of Obstetrician and Gynecologist, if the total score is 4 or more antenatally, we have to consider thromboprophylaxis from the first trimester. So for this female, we have to consider from the first trimester thromboprophylaxis. What is the dose? According to the weight, the dose will be 40 milligram daily. What about postnatal VTE prophylaxis? Anyone require antenatal low molecular weight heparin is a high risk. So this female will need postnatal thromboprophylaxis, and at this time, it will be 6-week postnatal prophylactic, not 10 days like the first 2 cases. But here, it's 6 weeks of postnatal prophylactic low molecular weight heparin. Now move to real case discussion, and actually it's different scenarios from what we said in the 2 webinars. We have Mrs. Ola, 49 years old. She went to obs-gyne physician complaining of vaginal bleeding, referred to oncologist because she had endometrial cancer. There is no metastasis, and the decision was total abdominal hysterectomy with bilateral salpingo-oophorectomy together with lymphadenectomy. But in the history of Mrs. Ola, she had femur fracture since less than 1 month, and she has irritable bowel disease. On physical examination, body mass index was 20 kilogram per square meter, and she had varicose veins. Surgical history, it's only for endometrial carcinoma here, ultrasound intracavitary lesion. On CT examination, we have that the chest was free, and for the abdomen, we have nothing. In the abdomen, we have para-aortic lymph nodes are not significantly enlarged. Uterus shows second endometrium. This is the investigations, and this was the biopsy. It was by pathology endometrioid carcinoma with a squamous differentiation in lower uterine segment. This is real picture of the surgery for this female with the samples taken for her. Now, how can you assess her risk for VTE? Is this female is high risk, low risk, or moderate risk? We will go for thrombosis risk assessment, which is applied for surgery here and not for obstetrics, not antenatal or prenatal, but from the surgery. We have risk, which take 1 point, history of inflammatory bowel disease. We have risk factors, which take 2 points. She has major surgery, more than 45 minutes. We have high risk, more high risk, which is 5 points. This is hip, pelvis, or leg fracture, less than 1 month. And we can give her a score. And according to the score, we bought the risk level. For this female, she has risk factor 5, 2, and 1. So it's 8. And she has a high risk. Beside the varicose vein, so it's now 9. And it's a malignancy, we have to add 2. So it's 10 now. So 5 or more in this female, it's 10. This female is high risk and she needs VTE. In surgery, it's very important to consider bleeding risk. So don't consider only VTE risk, but we have to consider bleeding risk because it's very important. And we have predictive value for this. For female she has recent major bleeding or has creat level, high creat level, more than 1.2 milligram per deciliter, anemia, cancer, or clinically overt pulmonary embolism or old age more than 75, we have a risk. Every one of this takes point, and so we have to consider the risk. We have low, intermediate, and the high risk. So we have risk for VTE, and we have risk for bleeding. We have to consider both. In this female, what's your choice for VTE prophylaxis? Low dose, unfractionated heparin, low molecular weight heparin, or oral. For these patients, thromboprophylaxis at low bleeding risk, the guideline suggests pharmacological rather than mechanical thromboprophylaxis. If we have high, low bleeding risk, we have to consider the pharmacological rather than mechanical. But if we have high bleeding risk, the recommendation is to use mechanical rather than pharmacological. And for patients with cancer and undergoing surgical procedure, low molecular weight heparin is the best one. And you have to use post-operative thromboprophylaxis or over pre-operative one. You have to continue this thromboprophylaxis after discharge of the female, and not only for 2 or 3 days in the hospital. You have to continue this. For patients with cancer, all patients with malignant disease undergoing major surgical intervention, they should be offered pharmacologic thromboprophylaxis, as we said, with either unfractionated heparin or low molecular weight heparin, unless contraindicated because of active bleeding, high bleeding risk, or other contraindication like allergy to the drug. And this is not only in gynecological surgery, but accounts for all of these risks. High risk for VTE, Cabrini score 5, we have to give low molecular weight heparin. So the choice for VTE for this female will be low molecular weight heparin. And for how long? It's only 2 weeks. As we said, we have to continue after discharge, only 2 weeks, 3 weeks, or 4 weeks. Extended prophylaxis with low molecular weight heparin will continue up to 4 weeks because it's a major gynecological surgery in the pelvis. We have to consider some issues. If we have to give spinal or epidural anesthesia or lumbar puncture together with this female who will take this thromboprophylaxis, there is a recommendation that we have to consider time. We have time interval between the last dose of this injection and the spinal or epidural anesthesia. If we give prophylactic dose, this free interval is 12 hours, should be kept in mind. And we have to wait 12 hours after the procedure, which is the spinal or epidural insertion of the catheter, for 12 hours after. So 12 hours wait gap between the last dose and 12 hours after the procedure. And take care, if you have your patient with creat clearance between 15 to 30 milliliter per minute, you have to double the dose, double the time. Instead of 12 hours, it will be 24 hours. If you give dose for treatment, you will wait for 24 hours interval before this puncture, and the dose will recontinue after 24 hours. And if you have high creat clearance, you will double the dose. It will be 48 hours. And we have to adjust the dose of the thromboprophylaxis according to the renal function, and this is very important. So we need usually consultation of our urologist with the dose if the female has a problem. And thank you for your attention.